Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We're delighted that you're able to join us virtually today for this webinar in our virtual webinar series. As a trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our insureds receive through the Trust. Three of our advocates are with us today, Drs. Jeff Youngren, Mark Martinez, and Lisa Bryant. In the interest of time, we've placed their bios on a slide. I hope you benefit immensely from this risk management roundtable. Please join me in welcoming Drs. Bryant, Youngren, and Martinez. Thank you in advance, team.
Thanks, Jana, and welcome to all of you. We are delighted to be back with you. And as usual, we're going to dive right into first few questions. We have 4 questions that Mark and Jeff are going to respond to already. And then as soon as we get through those, we'll dive right into your live questions. So, okay, Jeff, I'm going to start with you. And as you know, many psychologists, right, use texting and email in their practices. And oftentimes they'll say that they have, quote unquote, talked with one of their patients when they've sent an email or a text. Are there problems and risks associated with that?
Well, absolutely there are. I mean, it really is a kind of evidence of a generational shift from those of us who talked with people on telephones 40 years ago, and individuals who now have decided that texting and emailing are tantamount to talking with another individual when they're not. And they really are and can be very problematic. So the Trust recommends that we refrain from texting with our patients or clients, except if that exchange is a part of an active treatment program like DBT or something like that, and that emails be limited to administrative exchanges and not be used for the transfer of PHI, protected health information, which under HIPAA is identifiable health information. Why? Well, because that information is an electronic transmission. It's not talking to anybody. The communication is converted electronically and submitted and transferred electronically to an individual who received it. So many individuals think that little phone they carry, when they text to someone, they're really talking with them. But if you stop to think about it, you're not talking to them. You're sending an electronic message to them. In addition, you don't really know if they're getting it anyway. You don't know who is on the other end. So it's quite problematic. And we've done calls for years with individuals who've gotten themselves into some serious difficulty when they've transmitted confidential information through texting and the wrong person received it. So we encourage people not to do this. Don't think of your telephone, which you would talk on, as talking with anybody when you use texting as the mode of communication. And emails should be encrypted and should be transmitted usually in an encrypted web-based server, something like Hushmail or whatever, to make sure that you're in compliance with the HIPAA Security Act.
Thank you, Jeff. Mark, anything you want to add in there?
Just piggybacking on the point of the email encryption, I know myself, I know enough about computers to get myself into trouble, and sometimes not enough to get myself out of it, or at least without taking a few days. So I've actually retained the services of a local IT support, so that they've looked at my device, they've made sure that things are backed up, there's redundancies, that everything is encrypted properly. And so if you don't have colleagues who are in the know when it comes to encryption of your devices, then perhaps your psych association, local or state, would be able to provide you with some support or guidance on that issue. And at the very last ditch, there may be IT department or business locally who's familiar with HIPAA, especially, who might be able to help set you up and make sure that everything is secure and encrypted properly.
Yeah, no, that's a great idea. I've actually done something similar because I too am not a tech guru by any means. And I know, Jeff, you and I have talked some too, that sometimes one of the issues is that it makes it appear too that the clinician is always available, right? If they're always on texting. Do you want to comment a little on that before we move on?
Yeah, that's a great point. Yeah, I think that you have to stand back from texting and ask yourself if you want to create the perception that you as a clinician are available 24 hours a day, 7 days a week through texting. I mean, create some duty issues that could be problematic if you fail to respond to something that's urgent. But I think that creates a really bad foundation for therapy when you make yourself available, at least conceptually, from your patient's or client's perspective as an individual who's always there, ready to respond, virtually the doc in the box model. It's just it just is a dangerous turf once again to be involved in with individuals who think they're getting a hold of you and they're not for whatever reason. So I recommend strongly, and my colleagues recommend strongly, that you just limit that, and let's not use the verb talking to describe text message exchanges, because that is talking to nobody.
Right. Thank you, Jeff. Mark, okay, so changing topics just a little bit, because we've gotten some calls on this, and I think it may be that we're seeing a slight increase in this, but the question is, what should I do if I, as a clinician, learn that a patient or a client secretly or surreptitiously recorded a therapy session?
Yeah, it's funny. I actually received a call along these lines yesterday, and I agree. I think that they are gradually increasing in frequency, this topic, and it shouldn't come as a surprise to us given the advancements in technology and the general accessibility to devices that have recording capabilities. You don't have to look very far, much further than, say, social media, to see how people capture daily interactions and post them frequently. So when I receive calls about this, oftentimes the subject of the legality of this comes up, and states differ on this issue. So in one-party consent jurisdictions, it's permissible for one person who's a party to the interaction to consent on behalf of everybody there and to record within the legal framework. Other states adhere to what they call a two-party consent perspective, which I think is more appropriately named all parties. And in those jurisdictions, it requires that everybody would consent to a recording. However, it's important to note that the two-party or all-party consent states are in the minority. I believe there's somewhere around 11 the last I checked. But beyond the legality of this, I think it's important to focus on the clinical and the ethical issues, particularly if this is happening outside the awareness of the treatment provider, because this could signal some meaningful treatment issues that could be at play. Perhaps there was some sort of a distrust that's developed between the clinician and their client. It may be indicative of perhaps impulsive decision-making where consequences of actions aren't considered thoroughly before acting. And these types of treatment issues can have a negative effect on the process of therapy. And when this is discovered by treatment providers, oftentimes the feelings are negative ones. They feel as though their privacy has been compromised. They feel like they can't trust the client, perhaps. And that can, as you can imagine, undermine their effectiveness as a treating clinician, and certainly have the potential to damage the therapeutic alliance with the client. There are also confidentiality risks that the client may not be considering. This is protected health information, and how would it be stored, maintained? Do they appreciate how easily one click can distribute this type of material very far and very wide? There's also a risk, although I'm not familiar if this has actually happened, but there could be excerpts used for purposes outside of treatment, for, say, a custody dispute, or even perhaps even a board complaint. So how do we address this issue? Ideally, we would have a discussion, the informed consent stage. And I try to balance this. I think it would be in brief, or if you feel like this is something that's occurring in your practice or it's increasing in frequency because we're already overloading perhaps our clients in the front end with informed consent to begin with. But I think if it is relevant, and I think it's becoming more relevant, this is a good discussion to form an understanding with a client at the outset before we get to the point where perhaps they're secretly recording sessions without knowing that all of the consequences that could follow. If you do discover that somebody has secretly attempted to record, there are a few things that I'd recommend. First, discussing it in a neutral, respectful tone. Approach this as a clinical process-oriented issue. Even if you're feeling slighted in some way or some negative emotional response, try to keep this focused on a clinical orientation. Note that there are potential risks and benefits, as well as the importance of an open, trusting relationship in the therapeutic alliance. Invite collaboration from the client on how to come to an agreement on how to move forward. Explore the client's reasons for recording. Consider whether recording is something that both of you could agree upon, and what lengths you would go to make sure that it's secure and maintained so that confidentiality is maintained. Consider alternatives perhaps beyond recording, which could mean collaborative note writing or reviewing your notes with the client so that they don't feel the need to record. And of course, throughout this whole process, make sure that you're documenting all these considerations in detail.
Yeah, great. Thank you, Mark. Jeff, anything you want to add?
And I think it was a great answer to the question. I think that it just begs the question: is why is someone recording something? I mean, that has to be explored. And I think that if it's not acceptable to record, if that's not part of your policy, I don't disagree with Mark that you could include it in your informed consent. But remember, what we tell people is also informed consent. And you can make a notation of that. So if someone wanted to record and you disagreed with that, making a note of that in your records, it's obviously not signed, but the record lives on its own that you've talked about it. But I think, you know, it just begs the question, why is this going on? And there are venues within which recording does occur. In forensic evaluations, frequently things are recorded. But that's with the consent of all parties. So it's a different venue. So I think exploring it clinically is most appropriate.
Yeah, I agree. And I like how both of you have mentioned at different times, you know, you mentioned two of the big risk management strategies that we talk a lot about. One is informed consent and how we do that both in writing and verbally. And I think, Mark, you mentioned also the importance of documenting, right? If this does come up, you want to be sure you document conversations. And I'll add in the third, which is consult. You know, Mark, you mentioned, I think, you know, clinicians sometimes can feel betrayed, and it kicks up our own stuff if a client has sort of surreptitiously recorded something without our knowledge. And so whenever we're dealing with our own reaction like that, especially if it's a strong one, really good idea to consult at that time, especially maybe before we even go back and discuss it with a client. So we get sort of clear where we are and can have a more perhaps level-headed conversation. But right, great. Okay, so Jeff, I want to come back to you again with the texts and emails, because as you know, one of the things we recommend at the Trust is that all clinicians, if they're using text or emails or those kinds of things, have an established policy about how they do that. And so can you speak to why that's important and say a little more about that?
Yeah, Lisa, I mean, you made the point that, you know, we have this chair of risk management supported by three legs, and one of them is informed consent and consultation and record keeping are the three legs. And I think that the rules of therapy need to be set out clearly at the beginning. Clearly, you do informed consent as you go through treatment, but these kinds of policies are really benefit from being clarified to clients at the outset. We have model informed consents that people are free to download that talk about setting up those rules and making it clear why you do that. And so that if the patient or client has questions about that, you have the ability to explain that while emergencies are possible and you will try to assist with emergencies, emergencies should go to the nearest emergency room or dial 911 if you're not available, as opposed to creating a perception that if they send a text to you or an email that they're having a crisis, that you're just sitting there reading, your Outlook responses or questions from people 24 hours a day, which none of us do. So it's extremely important to think about that, especially with people who are really what we term digital natives, who are raised in the world where they think that these things are just natural parts of the way they communicate with other people. And I don't care if you do that with your friends and family, you can do whatever you want. But once you do it with an individual in a healthcare relationship setting, those become regulated by HIPAA primarily and by confidentiality laws in the respective states within which you live. And so it's not the same, it's entirely different. And you need to stand back and think about how seductive it is to think that you can use this as a way to talk to people when you're really, as I said earlier, you're not talking to anybody.
Mark, any additions?
I agree with everything that Jeff said. I also think, based upon some of the calls that I've had, it's, I think, natural for treatment providers to feel this pressure to be there, and that they may not be fulfilling their role if they are not there when a client needs them. And while I appreciate that, at the same time, I agree that having a policy in place is important. I think the other part is to make sure that you are abiding by it, because it's easy to have that creep where those boundaries become eroded over time. And it's really hard to reestablish those. I think it's more difficult perhaps to reestablish them than to reinforce them from the get-go.
Yeah, just to throw something in there, I mean, people need to remember that becoming overly concerned about something going wrong by creating increased availability or a perception of increased availability actually increases the perception of an increased duty on your part, the failure to which is one of the components of malpractice. So it's extremely important to make it clear to people what you will do, what you can't do, and to make sure that all those questions are answered. And people who get so worried about, I'm going to have a board complaint, or I'm going to have a malpractice action, which are really relatively rare, need to understand that by being overly available, creating the perception that you are available, just to make sure that you're managing the risk that way, is definitely driving down a one-way street the wrong way.
Yeah, and I like how you're both pointing out the importance, of setting clear expectations for the clients, especially those, as you say, Jeff, the digital natives who assume and expect one thing when it comes to texting. And I want to just mention, I mean, you both sort of said in different ways about, setting these expectations. And part of it is for clinical purposes, right? To make sure, and risk management purposes. And the other part is for self-care purposes, right? We can't and shouldn't be on 24/7, so if you're finding yourself responding to non-emergency texts late in the evening and on the weekends and times where you wouldn't normally be in your office, I think we do encourage you to rethink some of that, because that's probably, not good for you, the clinician, in addition to causing all these other issues that we're talking about from a clinical and risk management perspective. So I think both sides of that are important to think about. Okay, Mark, we'll come to you with the last question before we'll jump into the live questions. And thankfully, this is not one we get all that often because it doesn't happen terribly frequently, but it is important when it does happen, and it can be scary. So what steps would you say a clinician should take if and when they are harassed or even physically threatened by a client or a patient?
I think as a starting point, I would recommend taking all threats and harassment seriously. I also think it's important to make sure to consult as early as possible in this process once this issue emerges, and as needed until the situation is resolved. And examples of that can be contacting the trust for consultation or several consultations, relying on experienced colleagues, perhaps consulting with legal professionals or mental health professionals with experience on how best to handle and assess the harassment and threatening behaviors. And just to remind you, among the many benefits of consultation, some of the ones that come to mind in a situation such as this is that It allows our own emotions to cool because inevitably, I think most of us are going to experience an uptick in those emotional reactions if this occurs. It allows us to articulate the issues that are at play, and that helps us process them and make sense of them. We also have the benefit of receiving an outsider's perspective on the situation and possible solutions. And as Dan Taub often states, that this allows us to borrow someone else's prefrontal cortex for a bit. And so one issue in particular worth exploring during these consultations, particularly at the outset, is the manner and severity of the harassment and threats. So you can make sense of what's going on. And it also may be helpful to rely upon others, especially experienced colleagues, who might be able to point out any type of misperceptions on our part that could be at play, our own perceptions, and perhaps correct them as a means of trying to resolve the situation. So regardless of the severity, I recommend approaching this as a clinical process-oriented issue, much like the approach is suggested with recording sessions secretively. For moderate to mild cases, strive to remain receptive to the client's complaints, seek to understand the motivations further, attempt to collaborate with them, how best to address their concerns while using the ethical standards and principles as your guide. In severe cases, the conduct by the client very well may pose an insurmountable obstacle that undermines your ability to actually provide effective treatment. In these cases, concluding treatment may be indicated. You may consider the option, whether in person or through writing, respectfully and neutrally asserting your position and the need to discontinue treatment. And I'll remind you, under ideal circumstances, before we conclude treatment, we traditionally provide wrap-up sessions, with the duration of which are informed by the duration of treatment. We communicate clinical impressions as well as clinical recommendations we have and the accompanying risks if the person does not follow those recommendations. And we set them up with referrals and resources. If you consult and determine that this situation that you're faced with contraindicates this type of a traditional approach, make sure you document why in a matter-of-fact way in the client's record. If the threats continue after treatment is formally ended, consider, if appropriate, whether asking the client or sending a letter respectfully requesting that the client cease conduct from that point forward. And if the harassment or threatening statements persist further, consider case-specific information about the client. Consult again with experienced colleagues about next steps and the pros and cons associated with each of these. Some of these could include ignoring, with the hope that perhaps this would, the grievance would go away on its own and dissipate because any further engagement could inflame the individual further. Write and inform them that you'll no longer be responding to their contacts outside requests for records. Perhaps consulting with a private attorney about formal cease and desist letter or protective order procedures. If truly terrible, you may consider hiring a local expert who may be a member of ATAP, which is the Association of Threat Assessment Professionals, many of whom have a good deal of training and experience with dealing with stalking, harassment type behaviors. And of course, if there's a threat to your life, your safety, don't hesitate to call police. And if you do so, release only the necessary information to accomplish safety, to maintain safety. This can be minimal PHI as needed. The threatening behaviors in a factual way, sharing that you had a professional relationship with the person, but there's no need to go into the details. And importantly, once again, of course, document this whole process.
Great, thanks, Mark. That was a lot of very good information. Jeff, do you want to add anything there?
Yeah, briefly. I mean, this is a very important area. Psychotherapy is a structured relationship that has rules, and those rules bind both parties. And when one of the parties violates the rule, in this case, the client or patient, then the structure changes. And people frequently have said, wow, if I contact the police or get an attorney when I have a client who's stalking me or threatening me, is that a violation of the state law of confidentiality? Am I going to be in trouble? No, because you're not going to be. And there are many cases that support that, where individuals have actually taken that issue on in litigation, saying by going to the police, you violated my rights to confidentiality, and the courts always have ruled in the favor of the psychologist when the conduct of the patient or client is inconsistent with those structured rules. I mean, even our ethics code in section 10 that deals with termination says that you can end a professional relationship when the conduct of the individual, the consumer, is inconsistent with the rules. And so stalking you, threatening you, we get these phone calls from people, they go like, what should I do? What should I do? And you say, call the police. Call the police. Why is this a hard one? And then, well, is this going to be a violation? And Mark's advice is right on. Just tell them what they need to know. You don't need to say that the patient was molested as a child and is a borderline personality disorder and has difficulties with his or her spouse. You can say, I have a client who's threatening to kill me. And then you can get a restraining order. Courts support that. We do have power. So very important area.
Yeah. And one thing I left out that I wanted to just make sure, because this comes up a lot, is that people will often.
Oh,
I think, Mark, you're breaking up a little bit, at least on my end. Jeff, are you still there?
I'm still here.
Very
Okay?
sorry. Yeah, I'm not quite sure what happened. That's a first for me.
Actually, you were locked up for quite a while.
Was I? Oh, no.
Yeah.
Okay.
You
I'm
wanna-
sorry
yeah,
about that.
keep us a little bit on time here, Mark. Do you want to just finish your last statement before we dive in?
Yeah, I would refrain from blocking the person or trying to seesaw contact with them, because that can be very important in terms of escalated behaviors. And if you do get a professional involved, that could be very helpful for them to know.
Yeah, and I want to just add very quick, and I know we do need to jump on, but move to other questions. But one, I want to just say all of these can be very challenging cases. As a female working in forensics, I have had multiple, sadly, situations like this. They can be very scary. It can be very stressful, and every case is different. So I think Mark and Jeff have both given really good suggestions, but I wouldn't take those as like a prescription for every single case, right? Like, really important that you do consult. And I will add, I'm starting to think, Jeff, we need to add a fourth leg to that chair, because self-care is really important in this too. These are scary experiences, and sometimes they can change how you are with your other clients, right? If your fear gets really evoked, it can change how you practice. So I think adding that self-care piece is a really important piece as well. Okay, so we're diving now into the Q&A. First question, we'll now start to jump around topics a little bit, is with the No Surprises Act, will it be applied in 2023 or the following year? Jeff, you want to jump in? That's a pretty quick answer, I think, but what are your...
Yeah, it's actually, the implementation has been delayed, but it hasn't, people are wondering if it's been discarded, and that is not correct. So at this point in time, the implementation of this confusing regulation that was poorly thought out and poorly organized takes place. So I would say to all of you, stay tuned. We're on top of this, but it is an example of a bunch of bright minds getting together and writing up something that reflects the confusion of bright minds trying to agree.
Yeah, and I'll just add to clarify, I mean, Jeff's absolutely right. Some aspects of this have not been implemented. Some are on pause, but others have been implemented. Like, as of now, we are required to do a GFE, for instance. And as Jeff is also, my understanding is in alignment with his too, that come 2023, there may in fact be new changes or new requirements. So staying tuned on this is a really important topic. And as always, we will do our best to get out information as it sort of comes down the pike. So we have a question here about outgoing messages also, and what they should say. I think this is regarding emergencies. Should they add that the client should call 988 and or 911 for emergencies? Mark, do you want to comment on that, and maybe just generally what we should say in our outgoing messages regarding emergencies?
Yeah, I actually support that. I think it's a good idea, because ideally, as we've talked about briefly already, you have an agreement that if you're not on call 24/7, the procedures that the person should follow if there's a crisis. So having that reinforced on your message, your outgoing message, I think could be helpful. 988, I think that's also one of these, a newer option that is nice to include, as well as the traditional seek emergency help, either through mobile crisis, your local emergency department, or by calling 911.
Great. Thank you, Mark. Jeff, I'll toss the next one to you. Is it recommended to continue wearing masks when seeing patients in person?
It's a risk management question. It's and it depends upon what you're comfortable with and what your clients or patients are comfortable with. That while it's very clear that mask wearing and those mandates are becoming more flexible in their implementation, it's a question of what are you comfortable with and what is your client comfortable with and what is your policy. So if you're not going to use masks and you want to create an argument that you were still being prudent in managing an issue about the transfer of a contagious virus, if you do distancing from your clients, if you manage waiting rooms in a certain way, all those become arguments that you were attempting to at least deal with the issue. So I don't think we can just overlook this and go back to a world pre-COVID, because I think the whole world has been changed by COVID. But I also don't think that there is anywhere a written rule system that says that you have to wear masks. Do you want to reduce the risk by having that requirement? That's fine. You can do that. And if you don't, then what things do you need to do in order to make sure someone can't raise the issue that in fact you were fostering some kind of contagion?
Great. Mark, any addition? That was great, Jeff.
I had a call recently, and I'm failing to remember which state. I believe it may have been Minnesota, and I didn't fact check it, but the person had informed me that there was a mandate at the state level for healthcare settings. So I don't know if that, I didn't verify that, but it speaks to at least checking perhaps with the local psych association just to see if there are any healthcare specific mandates that are around. And I completely agree with what Jeff said in terms of the risk management of this issue, absent any types of mandates.
That's a great point. I mean, and mandates can be local mandates too. So I work in a hospital in a medical school. When we're in the hospital, we're supposed to be wearing masks. So that's a mandate that the medical school has implemented. And so, yeah, checking out, if there's a mandate, you need to wear a mask, or you're going to find yourself potentially in some administrative difficulty.
Absolutely. And of course, you can always make, individual exceptions if need be, not in a mandated situation, but you may wear masks with some patients and not others, depending on circumstances, if you have the option to choose. I do want to just for a moment, there's a question here again about the GFE. So I'm just going to quickly clarify. It says here that someone mentioned that we no longer have to adhere to the No Surprises Act and don't have to create GFEs. That is blatantly false. We do have to adhere to it, and we do have to use GFEs. So
yeah, I think that question also said that advice was from the trust, and that is not what the trust would say.
Absolutely correct. That is not. Okay, so there's a question here about HIPAA compliant encrypted email. The question says, what about HIPAA compliant encrypted email? But I think what they're asking is it okay to use HIPAA compliant encrypted email? And Mark, do you want to comment on this?
Yeah, I would recommend it, highly recommend it, if you're going to use email for transmitting any type of protected health information. One of the helpful things to look for if you're dealing with a company is a business associate agreement, whether they're willing to provide one to you, which would make them responsible and require them to adhere to data breach requirements under HIPAA. But absolutely, if you can find one of those that has a seal of approval and is consistent with the encryption and the processes outlined by the Security Act with HIPAA, then I would certainly recommend taking those actions.
Jeff, any added?
Yeah, I think absolutely using an encrypted platform for email communication is great. please, though, stop and think about why you're using it, and have the structure around that for administrative reasons. Transfer of PHI is fine, but I want people to make sure that there's an agreement between the client and you about what's coming your way, because that's regulated under HIPAA, and to make sure that your system is consistent with the HIPAA Security Act. Many of the billing services now actually have encrypted email services embedded in them, and that's fine. But why are you using email? It always makes me worry that we're not using email to chat back and forth with your client, the transfer of relevant documents, the completion of administrative forms, informed consent, etc. I have no trouble with that. The exchange between two individuals of therapeutic and psychological issues in an exchange might not be very wise.
Right. So I think what you're saying, Jeff, is that the HIPAA compliant encryption would sort of maybe solve the security issues, right? But it won't solve the risk management and at the clinical issues that may still encounter. So you want to be. I do want to comment that on our website too, there is a an article on there in the document library on how to choose encryption software. So that is available to all of you as well if you're looking into that. I want to note there's some questions here about specific programs or specific references. We're not going to be able to go into those kinds of details today, but if you have those questions, you're welcome to call us individually and do a consult specific to your scenario. But this is a good question that I want to get to. And the question is, if a patient signs a consent form about use of text or email that informs them of the risks of doing so, is the clinician protected? Jeff, do you want to start with that?
Is a clinician protected? Yeah, but it doesn't do away with the issues that have to do with the perception that you're available 24 hours a day, or that you potentially will lose control of the therapy relationship vis-a-vis the text and email exchanges. So, of course, if a client says, I'm willing to use the hush mail for the transfer of documents and information, they've consented, you've done it. You can't do it unencrypted, however, because that's a requirement under the HIPAA Security Act. And so making use of your Earthlink email, if anyone still uses Earthlink, not okay to do that. I don't want to find a way to get around the corner, to go back to doing what I would consider to be not good practice. You're not available all the time. This is not a person sitting next to you in a therapy session. And I don't think you want to create that perception at 10 o'clock at night when you're going to bed.
Yeah, I definitely agree. Mark, I'd be interested in your thoughts on this too. I have a slight different understanding of HIPAA, Jeff. I thought that HIPAA doesn't require encrypted emails. It, of course, highly incentivizes them because it says if we use unencrypted emails and there's a breach, then we have to do the breach notification rule. We've got to notify the Secretary of Health and Human Services. We've got to notify patients. Whereas if we're using encrypted emails and there's a quote breach, really there is no breach because then the email can't be accessed. So
I don't disagree. You're correct, but it seems to me that the answer then is use encrypted email.
I agree.
Right? So that it makes really good sense to use encrypted email because you don't want to do a breach. Breaches are small, they're not necessarily big, but they're a pain in the neck.
Yes, and to be clear to this question, if you use an unencrypted email and your patient has signed saying that's okay with me, that is technically, I think, legal via HIPAA. But if there is a breach, you are not protected. You still have to follow the breach notification rule. So it doesn't in that regard, nor just like Jeff was saying, it doesn't protect you from all the clinical issues. So I completely, I think we're all in agreement, Jeff, that encrypted, there's really these days no reason not to use encrypted email. Okay, another question. What do you recommend if a client refuses to pay, say owing $800 because of a deductible being met? They've been sent numerous invoices. They've also been sent a letter from a collection attorney to which they've not responded. Is small claims court an option? Mark, do you want to start on that one? Oh, Jeff, do you want to take it?
No, let Mark do it. Then
you were so eager. You had your hand up.
I want to be the color man.
I mean, the first impression that I'm left with here is, I mean, from a risk management standpoint, I also think this is a bit of a business decision, but the first question that comes to mind is, what do you have to gain versus lose here? Is perhaps the ramifications, even if you're successful in small claims of, say, getting $1,800, what might you lose in the long term in terms of the doctor who took their patient to court and won? And I think that I would balance it against that question. What do I have to lose ultimately here? And sometimes, as much as it may be painful, especially when the amounts go up the ladder, walking away, writing it off may be the easiest or the best course of action. But I think ultimately it's a business decision, but you also want to be sensitive to the type of confidentiality issues that are at play, and remain sensitive to the clinical issues, because you don't stop just because the bills stop being paid. And Jeff, I'm interested to see if you have a similar take or a different one.
No, it's not different. I entirely agree with you. I mean, there are those that get paid up front, and there are those who end up with bills they try to collect. And I think that when you say you have an $800 bill, my question to you is, why do you have an $800 bill? This should have been dealt with earlier, set forth clearly in your policy. And so you're not in the position of 800. That's not a lot. I've done cases where there were $20,000 in outstanding bills. And so the problem's not the patient. The problem in this circumstance is the therapist. Regarding Mark, very quickly, a personal story. When I was a young clinician, I had a person run up a bill for $183, and he tried to stiff me on the bill. So I did go to small claims court. It's before I was a risk manager for the trust. And he sued me for malpractice representing himself, alleged all kinds of nefarious things that I had done, which then brought the carrier in, and we had attorneys come in. He represented himself, and at the end of the story is that the judge threw out the malpractice claim and awarded me the $183. That was like 1985, and he still owes me $183. So
with interest.
I get to tell people I was sued for malpractice, but I think I made that bed that I slept in. You know, it wasn't a lot of money, and I should have let it go.
Well, yeah, I think you both make really great points. And I think, just to clarify in the question, in this case, the reason was that there was a deductible that hadn't been met. And my guess is the clinician didn't know that. And so that is one of those tricky situations where even if you're doing a good job of trying to collect at the time of service, you may or may not know, or, you know, that kind of thing. So that is harder. But
that's a good point.
Both of your points absolutely stand. No question. Okay, so there's a couple here. I'm going to sort of combine some of them, but, you know, to the point, Mark, you were talking about when someone is recording you, how valid is it if they have it sort of already in their informed consent that that's not allowed? What would you recommend sort of a clinician do at that point? And or how would a provider know if a session were recorded, and especially say if it's from a client that has a personality disorder, right? That kind of thing.
Well, the first question, what would you do? When you have an informed consent, they sign, in this example, that's a contractual agreement between you, and that's been violated. So I think I would still approach that in the same way, using some of the options that I discussed earlier, that this is a clinical issue, and determining what the motivation was and trying to explore that, and whether they feel the need to continue doing this. And you, as the treatment provider, if you're willing to agree to that, if they're truly set on making recording as part of the interaction. In terms of the second process, knowing whether they are going to record, that's a tough one, because even if you're using, say, Zoom, and you are alerted if somebody presses record, that doesn't mean that they don't have a nearby device that they have positioned to record. And you may never know. That's just the time that we're living in. But that may also speak to the importance, if that's something that's a concern, to at least address this and come to an agreement. And I suppose if it was used or shared, you had that policy in hand, and it was the agreement, it was documented, and it was violated by them. And I think there are many scenarios that can come about from that. They're kind of hard to to limit to just a few, but I think you'd have to deal with it on a case-by-case basis after that if it came up afterward. And Lisa, Jeff, what are your thoughts on that?
I don't disagree. I don't disagree.
Yeah, same here. I agree. Thanks. Okay, so this one, we'll switch gears a minute and go to telehealth. When doing telehealth, which state rules do you follow around file destruction when your origin state differs from client state's guidelines? Jeff, do you want to start with that? And maybe you can speak to, not that we want to go down a rabbit hole here, but you could also speak to if it's different under SIPACT or not.
Yeah, we really, I mean, that is a great question. And because the jurisdictional issues have not been straightened out there, I think that if you are not operating under SIPACT, which isn't my favorite toy, that you are operating under the license of the state within which you are located, even though there is argument under civil law that the transaction itself is taking place where the patient is. So the rules like child abuse reporting, elder abuse, and record keeping are regulated by the state within which you are licensed, because the other state doesn't license you, so that those standards don't necessarily wrap around you. When we get into issues of SIPACT, there are some things that are just out there unanswered, and I can't tell you what you should do. We do have a standard of 7 years or 7 years plus the age of majority, but that's different depending upon the state, right? I mean, I can't remember which state is 5, but we have some states that are 5 and some are 6, but I think that if you're operating from your state to California, which is one of the few states that allows interjurisdictional practice without a permit, they allow 30 days, that it would be arguable that the record keeping, you're the custodian of the record under the law, and therefore the rules of the state where you are would apply to that.
Mm-hmm. And this is a place too where I'd say, I mean, Jeff is right, the cross jurisdictional stuff gets very complicated sometimes. So this is a great place to consult as well. If you have a particular situation, because it can get complicated if you're licensed in both states, or, there's some complexities. So I think I completely agree.
That's a great point. Yeah.
And definitely consult. 2 quick things. One, someone asks, what are the 3 legs in addition to self-care? So good informed consent, good documentation, and having a low threshold for consulting and self-care. Those are, if we make it a 4-legged chair.
Well, you've added the 4th leg, but
yes.
Eric Harris's 3 legs were record keeping, informed consent, and consultation.
Right, exactly. So we're moving into the future by adding the 4th leg. And we have a couple questions on what is the GFE. That's a good faith estimate under the No Surprises Act. And I believe they have included a link in the chat to our guidance on that. So you can see that for more information. Here's another question I'm going to try to squeeze in now as many as we can before Jana pops on the screen for time. One question here, how do you best handle an online review that is unfavorable and inaccurate by a dissatisfied client? And this is important because we are seeing this happen more often. Why don't you start that one for us?
Yeah, first and foremost, don't respond directly. You got to keep confidentiality issues in mind, try to fight back that. I think a lot of us would share that defensive response where we want to correct the record. As an option, I've actually recommended on professional websites that people include some language to the effect of, please note that because of my obligation to client confidentiality, any commentary, any comments shared or posted here, any other site, either positive or negative, I will not respond to, but I invite you to share your thoughts with me directly. I think something to that effect will help you get across your obligation to the ethics, your understanding, and also it explains your silence if these things do come up.
Jeff, any additions?
No, I think it's a sticky wicket. It really, some individuals say and argue that you can respond. I think you have to be very careful with that. I mean, you dance close to violating confidentiality. I mean, Skinner was right. Sometimes nothing is a way to get something to stop in extinction. And because if you wander out there and start responding or say, this is a client that only came for 1 session and we didn't get along and the therapy fell apart, that really is confidential stuff. So I'd be very careful with that. I think that what Lisa suggested is right on. If you really have a question about that, give us a call. And I mean, we want people to use this service. It's there for you as a benefit, and it's a great service. Eric started this, and yeah, but give us a call. We'll be happy to talk.
Yeah, no, for sure. And you make a great point, Jeff. I know I've had some callers say, well, but the client, put all the information on there. How come I can't just respond? And you're right that the client's allowed to say anything they want about their therapy, but we are not.
Mhm.
So, so we can't necessarily respond. Okay, so I'm going to squeeze in another question here. This is a former client who I have stopped seeing due to treatment compliance. Is insisting that I complete long-term disability paperwork for her. I've told her, so this is a past, she's no longer seeing this patient. I've told her on more than one occasion that as her treating therapist, I will not do that, but I can confirm start and dates of treatment with release. She's insisting I complete the paperwork with treatment specifics and detail. Do I have further obligation here? Jeff, do you want to start?
Absolutely not. You don't have to do it. There's a small word in the English language. No, that's not your job. You didn't assess it. You weren't doing a disability evaluation. This is something coming out of therapy. While I have no trouble with clinicians authorizing short-term disability once or twice in a crisis, you are not filling out, we recommend strongly not filling out those forms. You're going into a forensic role. It's a role conflict. And you haven't done a disability evaluation because you haven't evaluated the situation forensically. I think Mark would agree, right? Right, Mark?
I do agree.